Good morning, everybody. Thank you for your patience. This is Paul Combes with Team Alvarez. Thanks for taking the time to join us this meeting. What we're going to do is just do a overview of the way that the managed care system works as it pertains to the payer relationship between the HMO plans and the IPA or physician groups. So just to get things started, we're going to cover some basic terminology. If at any point you have a question, the best way would be to probably enter the question in the chat box initially until the end of the webinar. And if you have not entered your name, just so that we have an accurate listing of who the attendees are, please do so. There's an option to change your name from viewer number 6 or 12 or what have you to the actual attendee name. All right. So just some basic terminology. Everybody knows what Medicare is. Medicare is the federal health insurance program for people 65 or older. That's who is the captain of the ship, so to speak, in this industry. Everybody knows what an MAPD plan is, Medicare Advantage plan. There are different types of Medicare Advantage plans. For any of the details that we will be covering, it's going to pertain to the HMOs. Okay, we're not any examples of payer relationships. It's not related to the connection is down. Nobody.
Reconnecting. It says reconnecting.
Yeah. I apologize if you lost connectivity. It's the internet is attempting to reconnect itself at this moment. All right. Sorry about that, guys. Technical difficulties. So again, any example that we are discussing today as far as payer arrangements, it's strictly related to the HMO products. Okay, it has nothing to do with PPOs, nothing to do with Medicare supplements, because those are essentially fee-for-service models, meaning you get paid as you do work. The next type of entity we're discussing is a management services organization, or referred to as an MSO. An MSO, they typically provide practice management and administrative support services to physician groups. The MSOs develop clinical guidelines and care standards, integrating the physician, the office-based practitioners with the medical groups. A very good example of the standards of care would be if you have a referral or an authorization that is to be processed, the authorization needs to have a minimum of a 14-day turnaround. Okay, some MSOs, they work differently. Most of the time you want it done a lot sooner than that, but at an absolute minimum, it would be a 14-day turnaround to meet CMS guidelines, and that's something that the MSOs, enforce, for lack of a better term. Some other examples of services the MSO provides would be processing of authorizations, collection and payment of claims, case management, meaning a patient goes to the hospital, there's an individual that tracks that activity while the patient is in the hospital, payer rate or service fee negotiation, payment distribution or disbursement, and risk pool management. Okay, so think of the MSO in a sense, like a sports agent. The sports agent, they handle all your finances, they do the collecting, the collective bargaining, so on and so forth. Okay. Authorization. Authorization is when a physician submits a request for a specialist visit or some other type of ancillary service to be provided. Services will not be covered without approval. The IPA has the right to deny or modify any authorization. So basically, a referral, which is a physician order or a prescription, if you will, it goes to the MSO or to the IPA, and that is either authorized or it's modified or it's denied. Okay, so think of the authorization as your hall pass, so to speak, to go and visit a different type of provider. A PCP is very, very important. They're really what steers everything within this IPA model. Okay, and patients can only be assigned to a PCP in an HMO model, which is a lot of times why you have difficulties, especially dealing with Medicare, Medi-Cal beneficiaries or the dual eligibles, because you have specialists who basically act as both the primary and specialty physicians. So they're kind of double dipping, and if a patient is assigned to an HMO, then that's going to significantly hinder their income, because most of the time specialists cannot practice as what's referred to as a dual affiliate. Okay, again, specialist, usually a specialist always has the base guideline of internal medicine physician, and there's the subspecialty such as cardiology, which is for the heart, pulmonology for the lungs, urology, the tract, the urinal tract, and this is why the physicians oftentimes can practice as a primary care physician, because the foundation of their expertise is in fact internal medicine. Okay. So now HMO, or health maintenance organization, that's really our bread and butter oftentimes. Many of you sell supplements as well, I understand that, but again, we're going to be discussing HMOs and how it pertains to the managed care 101 here that we're doing today. It's basically a closed network that works within the relationship involving PCPs and IPAs. The next example is capitation, which is a payment arrangement for healthcare service providers. This is the primary payment methodology that we'll be discussing today. There are other forms of payment and other arrangements between medical groups and IPAs, medical groups and primary care physicians. But just to keep things kind of short and sweet, because most of the providers, if they're heavily involved with managed care, then they tend to gravitate towards the capitation payment arrangement. So, risk pool. A risk pool is it's one of the forms of risk management most practiced by insurance companies. Think of it as a savings account in a sense, because what happens is for every patient that is assigned to a IPA, there's a percentage of the funds that are received from the health plan that gets allocated towards a risk pool. And the risk pool is basically, again, the savings account that would be applied towards any of the expenditures involving hospitalization, or emergency care. And any surplus that is left over at the end of the year, it gets redistributed back to, it gets split, depending on the arrangement between the health plan and the IPA, it gets split between the IPA organization and the plan, or the IPA organization and the hospital, and at which point they decide how they're going to disperse that money if they do so at all. Okay. The risk adjustment factor is the composite score of medical diagnosis codes that are attributed to a patient's health condition. Now, for those of you who maybe you sell property and casualty, or even previously when you were selling individual health, the risk adjustment factor operates similarly, where you have the built-in demographic score, but also depending on how how sick, for lack of a better term, the patient is, that score is going to be higher or lower. But oftentimes, if there's inappropriate coding or lack of coding, then the RAF is going to be lower than what the actual patient's conditions are. And really, the RAF is what dictates how much payment is received from the plan. Okay. HCC Coding, which is hierarchical condition categories. These are the chronic condition codes that are submitted on behalf of a provider's office to correlate with the disease type, its specific manifestation, and linkage within the body to other diseases or organs. Good example of this would be diabetes mellitus. There's not just diabetes mellitus, there's diabetes mellitus which is controlled, there's diabetes mellitus which is uncontrolled, and it also may have manifestations of other symptoms throughout the body. Now, the thing with HCC coding is that you want it to be as specific as possible, because the code type that you input on behalf of a patient's health makeup will determine essentially what the health plan is going to receive in terms of reimbursement. Okay. Again, the HCC codes essentially make up the RAF score. All right. So everybody's heard about the star rating system. The overall star rating, it combines scores for the types of services each plan offers for covering health services. The overall score of these services, such as staying healthy, managing chronic long-term conditions, if there is an improvement or not in managing those conditions, the member experience with the health plan, timeliness of authorization approvals, so on and so forth, member complaints, if those complaints were founded, or if there was any escalated action, and the timeliness of such, and health plan customer service as well. So all of these different domains, as they're referred to, are really what make up the star rating. Okay, yes, it is very heavily focused on clinical expectations, but that's not the only part of it. So if you talk to some health plans, they say our member service rating is a 5-star member service rating. So overall, that's going to play a part in the plan's overall star rating. So this is an example of the financial flow chart. Essentially, Medicare receives data as to what the RAF score is of a patient. Okay, the Medicare determines what monies are to be paid to the MAPD based on that RAF score. Not only just the RAF score, but each plan has they have a negotiated rate for services provided. Essentially, it's what's referred to as a capitation, where they receive a straight fee per patient, per member per month, or PMPM as it's referred to. The MSO, what they do is, again, think of them as the agents of the IPA. The MSO, they withhold whatever funds necessary to allocate towards risk pool management, as well as for their own management fees internally, and they distribute the remaining portion to the IPA. So essentially, the IPA is receiving a percentage negotiated rate from the MAPD for per patient, or excuse me, per member per month. Okay. Moving on. So once the money hits the IPA, again, they allocate a specific percentage towards the risk pool for every single member every single month, and this is not something that's optional. It's mandatory due to the contractual arrangements that they might have with with the health plan. But the IPA is completely responsible for distributing payments to the PCPs. Usually PCPs, they receive a, again, the standard model is capitation, but there are other payment arrangements. Remember, capitation is a projected bundled payment of X amount of dollars per member per month. The IPA is also responsible for paying each specialist visit. Most of the times, specialists are on a fee-for-service basis, meaning that they receive funds as they as they perform services. For the lab, X-rays, and other ancillary services, same deal. As it's needed, payment is distributed to them, which they rely on the claims to facilitate payment arrangements. Okay. So, what is the relationship between PCPs, MSOs, IPAs, health plans, and Medicare? So, the PCP, initially, they treat the patient and record the HCC data. Okay, that data is then submitted to the IPA. The IPA is responsible for extracting and submitting the HCC data for processing by the MSO. Okay, the MSO packages all the health plan. They package all the information for submission to the health plan. Okay. The health plan audits the data received, because if there's any what's referred to as upcoding, which is you're saying that the patient is in worse condition than what they are actually. So the MAPD is responsible for making sure that the integrity of that data. Tim, is there any way that you can look at her? So, again, at that point, the MAPD, they take that information and they submit it to Medicare, so Medicare can adjust their payment based on the data that's received. Okay? So, then once Medicare makes their payment adjustments based on the updated RAF scores that they receive, they submit that back to the MAPDs who receive their adjusted reimbursement rates for those same patient groups. Okay. Then the MSO, they adjust internally the capitation rates based on whatever information is updated. A lot of times what happens is they advise the IPA as well of low-performing providers, which in some cases results in a termination. The IPA manages the finances based on the payment received and dispersed back to the PCP, who finally gets paid for all his hard work and effort that they do daily treating your wonderful patients that you assign to them. Okay, so is the MSO independent of the IPA? Yes, to answer your question, the MSO is independent of the IPA. The IPA is essentially a client of the MSO. Okay, so a lot of times what happens is the IPAs, they can manage as many groups as possible. not as possible, but what they can successfully accommodate to remain timely with all of the responsibilities that they have. But there are some entities, for example, like healthcare partners, they own and operate their own MSO as well. You have other entities that you have other entities where they manage multiple groups. I can think offhand of one or two that they manage 8+ different IPAs. So how are the star ratings measured? Again, this is a breakdown of each individual domain that is an individual component of the overall star rating. Again, you have items relating to both Part C and Part D, staying healthy, screenings, tests, vaccines, managing chronic long-term conditions, rating of health plan responsiveness and care, member complaints, appeals, and choosing to leave the plan. The disenrollment rates are very, very closely monitored. Customer service, of course, drug plan, customer experience, how long did it take to get refills, was there any difficulty accessing medications, was there any complaints about the formulary that were unaddressed, so on and so forth, member experience with the health plan and drug pricing and patient safety. Okay. The importance of the PCP. Oftentimes, we within medicine tend to neglect the importance of the PCP. Cardiologists make a lot of money, but at the same time, they're not the ones who are really responsible for treating and maintaining the care of a patient. Okay, the PCP is essentially the gatekeeper. They're the one that directs the care. They determine the diagnosis of a patient, which, again, based on our chart from 2 slides previous, that really makes or breaks what the dollar figure is in terms of reimbursement. They submit the referrals. They're responsible for treatment and maintaining health. In some cases, you have examples where the IPA essentially incentivizes the PCP for minimizing the amount of referrals that they submit, because that's actually where a huge expenditure lies. Okay. So the PCP determines what codes are submitted, and again, each code has a different weight. You're taking the composite weight of all the codes submitted for one specific patient's makeup, which equates to the RAF score. So again, the HCC codes determine what the RAF score is, and the RAF score determines what the Medicare reimbursement rate is paid to the MAPD plan. Okay, so let's just go through a couple of examples, and you can see very clearly why this is important. Okay, so in this example here, you have a case where this particular patient has all of these specific diseases: diabetes mellitus with complications, there's vascular disease, congestive heart failure, as well as the linkage of the disease interaction between the diabetes and the congestive heart failure. Okay, but for whatever reason, this office or this PCP submitted no codes. So you have just what's referred to as the demographic score or the demographic weights, which is the 0.442, because this person, 76-year-old female, they live in whatever county you want them to be in, and they're Medicaid eligible, or as we refer to here in California, Medi-Cal eligibility. So overall, that composite RAF score is a 0.593. Okay. The next example would be some minimal coding inputted. All right. Maybe this doctor has an office manager who really could care less. They're having a tough time at home, so they're not being very thorough with their patient charts. Again, minimal coding. The only thing that is inputted is diabetes mellitus without complications. which is wrong because, as you can see, the following items after that, there are additional complications there. But that equates to a 0.711 RAF score. Okay. Now, here is an example of all the chronic conditions coded. Okay. You have and if you notice the weight of each individual item that's coded, as it adds up, that leaves a total of 1.810 for the total RAF score. Now, keep in mind that even though the codes are not correctly submitted, that doesn't mean this patient doesn't still have those diseases. And that doesn't mean that the patient is going to receive less care or treatment. Okay, this patient could be in the hospital every other month. It's just you're going to be receiving, as a health plan and as an IPA, less money for treating this patient based on the lack of coding. Okay, so just to kind of give you a more clear-cut idea of why this is important to the Medicare members, or excuse me, the Medicare Advantage plans, as well as the IPAs, because and again, don't get too fixated on the specifics of the numbers, because these are just examples, okay? But typically, on average, that RAF score is multiplied by $800, okay? So the health plan in this example is going to receive $474.40 for this individual to take care of their care. And as you can see, they have a lot of things going on. In this example, where it's a little bit better coding, you have a jump of a little less than $100, when in actuality the true value of this patient in terms of reimbursement is almost $1,500. And keep in mind, that still may not even be enough to treat this patient on an ongoing basis because of their complicated diseases. Yes, that's per member per month, because the patients, they stay on the plan every month. The health plan gets paid every month for these patients. The IPA gets paid every month for these patients. The physician gets paid every month for these patients. Okay. Now that you guys kind of have an idea of the way that the money flows, let's look at this chart again with some dollar values in there. And again, I'm going to discuss some percentages, but keep in mind that this is just to help put a framework. It's not, this is not exactly what physicians make. It's just examples here. Okay, so I just want to make that clear. So the example in this case, everybody strives for a 1.0 RAF score on average for all of their patient base. All right, and again, each plan has a different arrangement with Medicare based on what's referred to as a bid, but that's a separate conversation. So in this case, the MAPD plan is receiving $800 for this member per month based on a 1.0 RAF score. They allocate 20% of that for their Part D payments, as well as for administrative fees and costs, which equates to about $160 per member per month. Okay. The IPA is going to receive approximately 40% of that $800, which is around $320 per member per month. And remember, there has to be a dollar amount allocated towards the risk pool as well, which is about 40%, in case that you have your patients that go to the hospital. Obviously, there needs to be money in the bank to care for those patients in the facility. All right, and the IPA, they typically retain about 20% of the costs, which in this example equates to about $64 per member per month, because IPAs also have their administrative overhead, whatever rent, their staffing, so on and so forth. So the PCPs, you're allocating about 40% of those funds for the PCP. Remember, in the capitation arrangement, regardless of the money received, the PCPs get paid the same amount, okay? So in this example, it's going to be about $128 per member per month, all right, which is, you know, let's just call it an average for the sake of this example. And then you're allocating about 20% of those funds for referrals to the various specialties, which again in this example is about $64 per member per month. And then you're allocating an additional 20% for ancillary services such as lab x-rays, MRIs, CAT scans, so on and so forth. Again, another roughly $64 per member per month. Okay. Now remember, all surplus funds are redistributed within the organization, either remaining within the IPA or distributed in bonuses. So just as an example, if you end up spending a lot less on specialists than the average of $64 per member per month, then that's going to be additional funds that you have to distribute as you so choose at the end of the fiscal year. Same thing with the hospital risk pool. If this individual member does not go to the hospital at all, then you don't use anything from that hospital risk pool, and that's additional bonuses that are redistributed, you know, either throughout the IPA. Either they trickle down to PCPs, or you know, some executive in the office just gets a Merry Christmas. So let's look at this example with remember, because the coding makes a big difference. So let's look at this example with poor coding. Okay, you have a 0.5 RAF score, which is a lot less money there to play with, so to speak. All right, so that's about $400 per member per month. You still have to take a deduction for the Part D by the health plan, and in this case, yeah, it's going to be less money to play with because it's shrinking down to only about $80 per member per month. But at the same time, for all you know, this member may be taking half a dozen medications that are all very expensive. So that $80 is not going to even cover one medication. Okay? The IPA is going to receive less money as well because they have to go based on what the reimbursement rate is. And there's less money allocated to the risk pool as well, but this might be what's referred to as a frequent flyer, where they're in the hospital every other month. So that risk pool is going to be chewed up very, very quickly. In addition to the fact they still have to retain funds for their overhead as an IPA, and the fact that you still have to pay the PCP their contracted rate no matter what. So just between the PCP contracted rates and your administrative costs, the IPA has lost whatever money they've received on this patient. Okay. In addition to still having to pay the same 20% for specialists, you know, which is, let's just say $32 per member per month. But again, if this patient is very sick, and it's just a matter of very low coding, which is why there's a low RAF score, then obviously those specialist costs are going to be much, much higher. Same thing with the lab or x-rays or CAT scans and so on and so forth. Think of a person that you have somebody in office that hates their job and they don't put any effort into their work, and this individual that we're discussing here in this financial flow could have a very serious form of cancer, where it's going to require a lot of chemotherapy and so on and so forth. So remember, the PCP contract rates remain the same no matter what the RAF score is based on capitation. And in this scenario, at an absolute minimum, the IPA is losing $64 per member per month. Okay? So this, again, the whole name of the game here is risk management. Now, let's look at a scenario where the person is coded correctly according to what their health condition is. Okay? The IPA is going to be receiving $1,200 per member per month. Okay? You're allocating 20%, which is again about $240 per member per month for Part D. The IPA is going to be receiving $480. There's $480 allocated towards the risk pool. There's more money for the overhead based on this individual. And the PCP is going to receive the same funds. However, instead of it being 40% of the total cap received, now it's 27% because there's more dollars because of the correlation between the person's actual health condition and the reimbursement rate. Again, $96 for referrals per member per month on average, and you have the $96 allocated per member per month for the ancillary services. Again, just a reminder, regardless of what the RAF score is, the capitation or the payment rate remains the same. And in this specific scenario, that results in a surplus of $64 per member per month, which is, I think it's like $768 or something like that, roughly. So this is a positive gain in this scenario for the IPA. And that's pretty much the gist of it as far as, the way that the money flows. I'm going to go ahead and open it up now for questions. How do I do that, Tim?
Where is it?
Hold on. There we go.
There you
On the list for but you can see the difference in making sure they code properly, how much more money they have to work with the service.
Hello?
All these doctors are good.
Hello.
Hello.
I have a question.
Sure.
My name is Pamela Bernard, and I'm on the phone, so I can't see your presentation that you just did. Can you email me that presentation?
We made a presentation.
Let's
the doctors to make the
There's
patients
somebody talking in the background there.
services performance.
sorry for your information. I'll make sure that share it.
People here, whatever, they're practicing night. So we've got a good rapport, obviously.
Anybody else have any questions?
Hello?
Hello?
Somebody's talking to me.
But she one time was a CEO of Delta IT, which was an IT local.
I think I hear Gary Duquette in the background.
Originally Foundation Health around anymore.
My name is Pamela Bernard, and I'm on the phone, and I can't see your presentation. Can you email that presentation to me?
I heard your question, and like I said, this is for partner information. So I'm able to share that with you.
Trying to do crime to get help with doctors because they don't have one small medical people. They only have one office. They have about 15 doctors.
This presentation.
Employee one medical group, 15 doctors. So we possibly feel really jump up and down, and I get signed by the
Sounds like somebody's on the phone, but
leaps and bounds above all the medical. And then because of the efficiency of the sound, that's a lot. So now they're kind of bigger. So anyway, so we got a good reporter and we'll keep it going. Do a good job now. We like to work with doctors.